We just discussed for the new participants. So how to differentiate one pathology from the another. So what is the importance of special test? Okay, that we are going to discuss today. Now I'm closing the waiting room. Okay. So first we will know what are the range of motions of the cervical and the shoulder. So whenever we are doing any special test, we don't do it aggressively. What is the range, at what range we have to do? That is most important in performing any special test. So we do not harm the patient by pressing or by aggressive bending the neck or the shoulder. Okay, so we should know the range of motion. So for neck flexion, it is about 0 to 45 degree, and extension also 0 to 45 degree. Okay, rotation 0 to 70 degree, both the side. Okay, lateral bending 0 to 40 degree. So don't think that your neck will go like this if the shoulder is coming. It is 0 to 40 degree. Okay, shoulder flexion about 0 to 180 degree, extension 0 to 45 degree, external rotation 0 to 45 degree, internal rotation 0 to external rotation 0 to 90 degree, internal rotation 0 to 90 degree. Okay, adduction 0 to 45 degree, abduction 0 to 170 degree, 180 degree, like that. Okay, fine. So let me start. Okay, to discuss the range of motion. Okay, it's very important. Prior to any assessment or special test, you should know the range of motion. So first we'll start with cervical spinous process examination. How you examine the cervical spinous process? You just have to make the patient sit or stand and maximally flexed. Okay, so where you feel the bump, that is your T1. Okay, when you bend, where you feel that bump, that is T1. Okay, so how you'll notice that C7, the C7 is the more mobile. Okay, when you extend, the C7 goes anteriorly. Okay, inside. So you will be able to count how the cervical vertebra. Okay, so this is the cervical process examination. This is the first test. Most superior prominent fixed point palpated on the cervical spine. Like this. Okay, now next is the Sperling test. We make the patient sit upright, okay, on examination table, extend neck 30 degree and look to one side. Okay, just extend and look to one side, and the therapist will apply minimal pressure. Okay, not so hard or not so soft that you do not get those symptoms what you want. Okay, just a minimal pressure to moderate force. Okay, when there is a pain or numbness in your both upper limb, okay, so it tells you about any nerve root compression. Okay, is there any facet or posterior element, any disease? Okay, so this will, and you should take caution if the patient is having stenosis or arthritis or compression fracture. You do not have to perform this test on these patients. Okay, like this. In the drop arm test, you already know all this test. Abduct the arm to 90 degree in coronal plane, then horizontal adduct 45 degree, and ask the patient to slowly lower. You don't have to touch the patient. You just have to tell him that you have to abduct your arm 90 degree and in coronal plane and horizontally adduct 45 degree. If the patient lowers, okay, if the patient is having severe pain, or if the patient is not unable to lower the arm in controlled manner, it shows there is a rotator cuff tear or significant tendinopathy. Okay, this is the test. Just you have to instruct the patient and patient will be able to do. Just have to see, do not palpate. Then the resistant external rotation, make the patient sit, okay, 90-90 position, elbow touching your thorax, okay, and just resist by, and ask the patient to do external rotation and you have to resist it. If there is a pain or weakness, there is a rotator cuff or a posterior deltoid dysfunction, okay. Like this. Resisted internal rotation, same sitting position. Now you have to resist the internal rotation. If there is a pain or weakness, there is a rotator cuff tendinopathy or a subscapularis dysfunction. Okay, and with that you have to keep it in mind. If there is a pectoralis major or teres major contribution, if their muscle strength is also affected, this will also affect the internal rotation. And if the trapezius is weak, it will may destabilize the scapula and also cause false weakness of the internal rotation. Okay. In Patet test, you have to ask the patient, sit, elbow flex to 90° and abduct to 90° and externally rotate. Okay, 90-90 position, elbow also flex and abducted to 90° and you have to keep your shoulder like this. So the fist is shown downwards, and ask the patient to externally rotate it. Ask the patient to externally rotate. Okay, you have to resist it. If the patient is having pain in the shoulder or scapular region, so that shows there is a tendonitis. Okay, if there is a pain, okay, patient is able to do it and patient is only feeling the pain, so that means that is a tendonitis. But if there is a rupture, that means the patient is not able to hold this position for long, or patient is not able to is not able to position that. Okay, so that means there is a teres minor or infraspinatus rupture. Okay, like this position, if the patient is not able to hold this position, so that means there is a rupture. And if the patient is able to hold the position and with pain he is able to do, that means this is a tendinitis. Then empty can test, shoulder abducted to 90°, angled forward 30°, elbows fully extended, forearms fully pronated so that the thumb is pointing downwards. So what you have to do in this position, the therapist has to apply the downward pressure to the distal forearm. Okay, and the patient tries to attempt to resist that movement. And if the patient reproduce that pain, so that means there is a supraspinatus tendinopathy. Okay, shoulder abducted to 90°, angled forward 30°, elbows fully extended, forearm fully pronated. Okay, and you have to resist the movement at the forearm like this. And lift off test, this you can do in prone position also, and standing also. What you have to do, you have to take the patient's arm backside, okay, and ask the patient to lift the your palm up. If the patient is not able to do, inability to lift the dorsum of the hand up, so this shows there is a weakness in the subscapularis, latissimus dorsi and rhomboides. So in this, one thing can occur. With this, the patient may not be able to lift the dorsum of the hand, or may try to extend the elbow also, because this will be in flex position. Okay, so if it is so that the patient is extending the elbow with that and not able to lift the dorsum of the hand off the back, so this shows there is a weakness in the subscapularis, latissimus dorsi and rhomboides. like this in standing. Hawkins test. Next test is the Hawkins test. Flex the elbow and shoulder to 90° with shoulder internally rotated so that the fist is down. Okay. Flex the elbow and shoulder to 90°. Okay. Like this. Now stabilize patient's arm by holding proximal elbow. Proximal to the elbow you have to hold and apply tension to the anterior distal forearm to maximally internally rotate the, you have to resist and ask the patient to internally rotate. Okay. So if there is a pain in the area of acromion, so that is the impingement syndrome. So for impingement, you have to do the Hawkins test like this. You have to resist down at the wrist joint and you have to stabilize, okay, at the elbow. And you have to just resist the movement. If the patient produces at the pain at the AC joint, that means it is an impingement syndrome. The knees test. Okay, in this you have to extend elbow and pronate forearm so that the thumbs are down. Lift the patient's arm in flexion, 30° in coronal plane, passively extending the shoulder to end range. Okay, you have to lift the patient's arm in flexion and 30° in coronal plane and passively extend the shoulder to end range. Okay, if the patient produces the pain, it shows that there is an impingement syndrome. Okay, you may also stabilize the scapula if you want the more perfect sign. So it will cause more impingement and it will show there is impingement of the supraspinatus like this. Scouring maneuver, flex both elbow and shoulder, abduct. Okay, you have to bend the elbow and shoulder in abducted and internally rotated so that the fist is down. Okay, same what we have done in the Hawkins test. Okay, then passively internally rotate the arm. So if when you internally rotate the arm from flexion to extension like this, okay, the position is like this, and from the flexion position of the shoulder you are bringing the from forward to backward. Okay, so when you bring the shoulder in extension position, okay, so the patient will produce pain. This is also, there's a test for impingement syndrome. So we have seen the 3 tests for the impingement syndrome. Okay, now the Apley scarf test, cross arm test. In this, what we have to do, you just have to flex the shoulder to 90° and bring this position. Okay, and you have to feel the AC joint. If the patient feels any, if the therapist feels any pain or shifting or clicking sound while doing this movement, that means there is a acromioclavicular joint dysfunction. Yergason's test. In this, what we have to do, you have to ask the patient to sit on a chair, elbow flexed to 90°, forearm pronated, okay, and grabs the patient's forearm just proximal to the wrist, and you have to resist the supination movement. Okay, the hand is pronated and you have to resist and ask the patient to supinate. If there is a pain in the bicipital groove, where is bicipital groove? Is the groove between the, anyone can tell me? Anyone? Okay, the lesser tubercle and the greater tubercle. Okay, when you have to feel that, palpate that area. If there is a pain in those bicipital groove area, that means there is a bicipital tendonitis. That shows that the Yergason's test is positive. Okay, so there is one more test known as the modified Yergason's test. In this same you have to do, you have to make the patient sit, forearm pronated. Now you have to do the 2 movements. Ask the patient to, you have to resist the, ask the patient to do supination also and external rotation also. Okay, in first what we were doing, only the external, supination. But in modified Yergason, what you have to do, you have to ask the patient to do supination also and external rotation also. If there is a pain in the bicipital groove, okay, and there is a subluxation also, so it shows there is a bicipital tendinopathy or tendon subluxation or any subscapularis injury. Like this. In this, we are asking the patient to perform 2 movements. A speed test. Flex shoulder to 50° with elbow in extension and wrist in supination. Provide the downward force on the arm and attempt the extend the patient shoulder. Okay, we'll ask the patient to, we have to give the downward force so that the shoulder is goes in the extension. Okay, so if there is a pain in the bicipital tendon, it shows that it is a bicipital tendonitis, like this. O'Brien's test. Okay, position upper limb with shoulder flex to 90°, horizontally adduct to 15°, and maximally internally rotate so that the elbow is extended. And you have to just apply the downward force to the distal forearm. Okay, if this is this you have to do, and what your patient will feel if there is a pain or audible click in the acromioclavicular joint. It shows that there is a acromioclavicular joint dysfunction in the AC joint, like this. And this you can also perform, this we have done in external rotation, but you also have to do in internal rotation, do the external rotation also and internal rotation also, both you have to perform. Then apprehension test. In this, what you have to do, make the patient lie on the table, on the couch, and the arm is hanging out and the shoulder is abducted to 90° and elbow flexed to 90°, like this position. Okay, so it will, the shoulder will go in maximum external rotation. Okay, when you apply the posterior directed force on the distal forearm. Okay, in this in this two pressures are being given. Okay, here when you hold one hand here near the wrist, you have to give the posterior force, and one hand on the proximal shoulder, you have to give the anterior force. Okay, so when there is a pain, it shows that there is a anterior shoulder laxity. Okay, two pressures are given in the apprehension test. Okay, now the relocation test. In this, what you have to do, it's same like the above test. Patient lies on the table, arm hanging, shoulder is abducted to 90°, elbow flexed to 90° and maximally externally rotated. Stabilize patient's arm by holding the wrist with the palm of the hand. Direct the posterior force. Now at the palm of the hand, you have to give only the posterior force, and the above side, you don't have to give any pressure anteriorly or posteriorly, just at the palm of the hand. So if there is a pain or sense of shoulder instability, it shows as the anterior shoulder laxity, like this. In the first, we were giving two pressure. In relocation, we are giving only the one pressure. Surprise, anterior release test. Patient lies on the table with arm hanging off the edge. Shoulder is abducted to 90°. Shoulder maximally externally rotated, same as the relocation test. In this, what you have to do? You have to perform the relocation test. How we were going? We are giving pressure at the wrist joint. Okay, and you have to suddenly release the pressure. Okay, you have to give that pressure and you have to suddenly release the force at the glenohumeral joint. So when you release the pressure, there is a return of the symptoms. Okay, return of the symptoms of pain or instability. It shows that the anterior shoulder laxity. Okay, we were giving pressure. Okay, now just released. Next test is the Edson test. Rotate head to one side and neck extended, and shoulder at 45° abduction and elbow fully extended. And with this position, you have to ask the patient to maximally inhale, maximum inspiration patient has to do. Okay, and you have to feel the bilateral radial pulse. In both the hands, you have to feel the radial pulse. If the pulse disappears and the patient complains of any tingling or numbness in the limb, it shows that there is a scalene compression of the brachial plexus. Okay, in this only one radial pulse the person is seeing, but you have to see the both in both hands. Lens test, shoulder abducted to 90°, flexed elbow to 60°. Okay, grasp patient's distal forearm and passively internally rotate and extend the shoulder while palpating the radial pulse. Okay, if the pulse disappears when the head is turned away, it shows that there is a vasogenic thoracic outlet syndrome with loss of pulse. Okay, just like we see in the thoracic outlet syndrome. Okay, you will feel the loss of the pulse. Postoclavicular test. Patient sits, stands. In both the position you can do. Ask the patient, you have to stand behind the patient, palpate both the radial pulse, okay, with shoulder in 10 to 20 degree of extension, and then patient then thrust out test. You have to ask the patient to expand the chest. Okay, when the patient expands the chest, there is a disappearance of the pulse. Okay, this shows there is a compression in the brachial plexus. Like this. Okay. Bruce test. In this, you have to raise your hand to 90-90 position, abduct the shoulder to 90 degree and elbow flex to 90 degree. And you have to ask the patient to do open and close your hands for 30 to 180 seconds and see the patient's hand. If there is a reproduction of the symptoms or if they are accompanied by pallor, color, discoloration of the hand. Okay. So this means there is a thoracic outlet syndrome. Like this position. And there is one right hyperabduction test. Stand with elbow flexed to stand with elbow flexed to 90 degree. Palpate the okay. In this, you have to stand with elbow flexed to 90 degree. Palpate the radial pulse. Okay. Slowly abduct and flex patient's arm to 130 degree. Okay, and you have to palpate the radial pulse with the, you can palpate with your hand also or the stethoscope also. And if there is a disappearance of the radial pulse or there is a forearm or the forearm numbness, okay, this means there is a compression of the great vessels between ribs and clavicle or compression of the brachial plexus. Okay, this way. Okay, so this all I finished with the special test. Anyone having doubts can ask me. Hello everyone. Do you have any doubt in this special test? Mute everyone. Hello everyone. Any doubt in test? So we can revise if you want. Okay, let me check the what's chat if there are any doubts. Okay, someone is asking Hawkins test. What you have to do, you have to flex the elbow and the shoulder to 90 degree, okay, and internally rotate it. Internally rotate your this, okay, shoulder. Flex the elbow and shoulder to 90 degree. You have to internally rotate so that the fist is downside. Okay, now stabilize the patients up by holding one hand at this elbow joint. Okay, and one hand you are giving pressure. Sorry, stabilize patient's arm by holding proximal to the elbow while applying tension on the distal forearm to maximally internally rotate. Okay, you have to place your therapist hand will be one here and one hand here. So therapist internally rotate it more. Okay, and one hand will stabilize the elbow and one hand will more internally rotate it more. So if there is a pain or patient feels pain, there is a reproduction in the pain in the shoulder area, that is the test for impingement syndrome. Okay. Let me check anyone. Someone is asking for speed test. Okay, in speed test, what you have to do? Flex the shoulder to 50 degree with elbow in extension and wrist in supination. Okay, shoulder flex to 50 degree. Elbow should be extended and wrist in supination. Okay, and provide downward force on the arm. Okay, provide downward force on the arm like that the shoulder goes in extension. Okay, you have to press at the distal forearm so that the shoulder goes in distal extension. So if there is a pain in the bicipital tendon, that means there is a bicipital tendonitis. Okay, hope Samana Athar and Pragati, you got the test. Okay, Dr. Priyanka, drop arm test. Drop arm test is very simple. You don't have to touch the patient. You have to stand and ask the patient to sit or stand. Abduct the arm to 90 degree in coronal plane and horizontally adduct to 45 degree. Okay. So what you have to ask the patient to do? 90 degree abduction of the shoulder and in coronal plane and horizontally adduct to 45 degree. And ask the patient to slowly lower the arm. Okay, you have to ask the patient to slowly lower the arm. When you ask the patient to slowly lower the arm, there is a severe pain or patient is unable to lower the arm, okay, in an uncontrolled manner. So that shows there is a maybe rotator cuff tear or a tendinopathy. Okay, hope Dr. Priyanka you are clear. Okay, someone is asking for scouring maneuver. Okay, it's very simple. What you have to do in scouring maneuver, it's for impingement syndrome. You have to ask the patient to flex both elbow and shoulder to 90 degree, and you have to flex the elbow and shoulder to 90 degree, shoulder abduction and internal rotation. Okay, shoulder abduction and internal rotation, so that the fist is going downside. Okay, like what we have done in the Hawkins test. Okay, now what you have to do? The passively internal rotated arm. This you have passively done. Internally rotated arm. You have to move from the shoulder which is in forward flexion to extension. Okay, you have to take the shoulder from flexion to extension, back of, okay, near back of the buttocks. Okay, and the patient if the produces pain, that shows there is an impingement syndrome. Okay, this is the scouring maneuver. Okay, any more doubts? Hope I am clear with all this. Any doubt, you can ask. Okay, so I think there are no more questions. So we can finish up the session. Okay. Okay, fine. Oh, okay. One more question. Speed test. Okay, in speed test, what you have to do? You have to ask the patient to do shoulder to 50-degree flexion, elbow in extension and wrist in supination. Provide downward force at the arm so that the patient attempts to extend the, we're able to extend the patient's shoulder. If there is a pain in that area in the bicipital tendon, that shows the bicipital tendonitis. Okay, hope I am clear with all the test. If any problem, you are all in the groups, you can ask, okay, and we can discuss this again, okay, or I can share you the video. Okay, thank you very much. So we'll finish up the session, and thank you for your time on this Sunday evening. Okay.